Christine, great to see you again.
You too. It's been
Ta-
so long.
I'm taking time out of my vacation to chat with you, and hopefully our students get a
Yeah.
little education from it. So, um, all right, you want to get started? What do you want to talk about today?
Let's talk about the respiratory system and diseases. What is that? How do you think that sounds?
Uh, well, listening to the lungs is one of the things we would do for these pathologies. So I think it sounds pretty good. All
That
right,
was a
let's get
reach.
a little bit. I'm on vacation. My best material is also on vacation.
Oh yeah.
All right, so let's get started. So first off, we're going to just talk broadly about some treatments that we can have for some respiratory disorders. So medications we could use: decongestants, which will induce vasoconstriction in the mucosa, reduce edema; expectorants, which thins secretions for easier removal, either mechanically or by coughing; antitussives, which will reduce the cough reflex, decrease the frequency of coughing; antihistamines, block allergic responses; analgesics for pain; antimicrobials for different infections; bronchodilators to open the bronchioles and allow more air to pass through; and glucocorticoids, which are an anti-inflammatory and anti-allergic. There's a couple of surgical interventions that we could also use as well. How do you pronounce this first one? What is that, Christine?
Thoracentesis.
So removing excess fluid from the pleural cavity; tracheotomy, an incision into the trachea. So now we're bypassing the mouth to get air in. And then different surgeries: tumor removals, removal of damaged lung tissue. That could all, different surgeries could happen. So
For occupational therapy treatment perspective, if you go back to the
yep.
surgical interventions, one practice example that I have is when I was working in a community program for survivors of brain injury, and I was working with a women's group. One of the topics that came up is how they felt about their scarring from their tracheotomies. And so that was one of the occupational therapy interventions, was working on group intervention for them to discuss and support each other around the scarring and things like that.
Yeah. Yeah, I think in our integumentary conversation, we talk about you can't minimize the importance of that cosmetic appearance, and especially with, especially for women, men typically have more collared shirts, higher shirt lines. Women's a lot more neck exposed. Yeah, it's a big deal. So definitely important for us. Thank you for telling that. So some basic therapies we could have for respiratory disorders: well, reduce the irritants or exposure to the irritants. Make sure you have your immunizations up to date, especially flu and pneumonia vaccines. Humidify the air. That's going to moisten mucosa, resist some damage, then remove other secretions. Moderate exercise is good. What moderate means for the patient is highly individualized, especially if they have these disorders we're about to talk about. But some examples: walking, swimming, again, within reason. There can be some breathing and coughing techniques. We'll look at some specific examples in a little bit. Chest physiotherapy, oftentimes called chest PT. There's also respiratory therapists that do this as well, even though it started in the physical therapy world. The respiratory therapists have taken over a lot of it. But even families, we'll show an example of some families providing these interventions as well. Just to remove the thick secretions, reduce infections, and different oxygen supplies. Now, one thing in the home care setting, when someone has to have oxygen, it automatically puts them at a high risk for falls because the oxygen lines, traversing through the house get hung up on things. It's easy to trip over the lines themselves. So that is definitely something that we have to manage. It doesn't matter what the profession is. If you are in someone's home and they have oxygen, we are always talking about oxygen line management and avoiding trip hazards. And that's always a battle.
Mhm.
So scar management also potentially needed. Postural education. So big example of this, I think you and I can do this right now. Hopefully our students will do this as well. If we slunch down, if we really, slouch and try to take a deep breath, and then we sit up all the way, have nice, good posture that grandma would be proud of, and then take a deep breath. Which one feels better? Well, obviously the one with the good posture. That's because our diaphragm can contract the way it's meant to, our lungs can expand the way it's meant to, and we can intake more volume of air. Well, maybe our patients have lung disorders that we can't improve upon. The disease is still going to be the disease. But if we simply improve upon their posture, they then can breathe easier because we're not restricting their lung expansion because of poor posture. So if you have somebody with any of these conditions that we're about to talk about and anything that affects the lungs, automatically day one you can start on postural education.
Mhm.
Different
Also
secrete. Yep.
positioning.
Yeah,
If someone is in a wheelchair, looking at their position in a wheelchair, looking at their positioning when they're lying in bed to see how their posture is as well.
absolutely. Um, and secretion clearance, either mechanically, different suctions, or with coughing, hacking techniques where you're actually having the patient force secretions out. A lot of different breathing exercises, diaphragmatic breathing. We can put our patient in the supine hook lying position to encourage the abdomen to expand. Sometimes that's an easier way to see the abdomen expand than when we're seated or even standing. Lateral costal breathing, right? Trying to really focus on expanding our ribs in the lateral way. Putting our hands on our patients and telling them, push your ribs into my hands. It can be tough for our patients to understand what that mechanically feels like. Pursed lip breathing, almost like you're blowing out a candle, right? So that can help. Boxed breathing, hold in for breathe in for 4 seconds, hold your breath for 4 seconds, breathe out, take 4 seconds to get the air out, hold for 4 more seconds, then breathe in for 4 more seconds. That's also something that can be really nice for our patients who might have anxiety. A good way to calm down, good way to have maybe a de-stressful moment, even for our students if they're getting nervous during one of your exams, Christine. All my exams are easy, so they don't get
Mine
nervous.
are terrifying.
Yeah. Um, Another thing we can always look at, relaxation of accessory musculatures of breathing. So scalene, serratus anterior, upper trap. Sometimes you can see when people are working so hard, all of these accessory muscles of breathing are trying to yank up on the rib cage just to try to expand it so they can take in more air. Different assistive devices and postural drainage we'll look at next. So postural drainage I love because with our talent of being able to listen to somebody's lung, if we're good enough, and I'm always just okay at this. Sometimes I ask the nursing staff that I like to work with, okay, which segment is blocked? Which segment has the mucus in it? Which segment is the one that needs to be drained? If I know which segment, either because of my own talent listening to the lungs or having somebody else explain it to me, we then use gravity to help us drain that. So if all we're trying to do is get whatever section of lung that's filled with mucus, and we're tipping that up. So hopefully we drain that mucus out of the body. So I think the easiest thing to see, the easiest visual on the bottom right, both lower lobes looked in red. Well, in order to drain that, we would just tip the person in a Trendelenburg position where their head is lower than those blocked areas. So gravity will help draw that mucus out of that area that they're having trouble with. So I love using postural drainage. It's really easy. So we could have upper respiratory tract infections, a lot of different reasons for that, viruses, bacterias. It's important for us as healthcare workers just to understand basic infection prevention to minimize spread. So standard precautions, airborne precautions, now using N95 masks. So some of the things you might see: common cold, rhinovirus, sinusitis. What's this third one here? Help me with that one.
Laryngeotracheal bronchitis.
I call it croup. That's
what I call it.
No, well, you've got a lot of more time on your hands. I have to get to the point. A common viral infection for kids, really 1 to 2 years old. That's the big one, big age group for croup. Epiglottitis, bacterial infection, flu, scarlet fever. Used to be a serious childhood disease, but now generally treatable with antibiotics. You don't hear too much about scarlet fever right now. Lower respiratory tract infections. We have some of them. RSV is the common one. Again, for kids. Pneumonia, Legionnaire's disease is another common one. The one I hear about Legionnaire's disease, you might hear about it on cruise ships or in spas. So because this bacteria really lives in warm, moist environments like air conditioning ducts, systems, spa type settings when the air is warm and moist. So that's something that we should understand. So first up, we'll talk about pneumonia. So pneumonia is a primary acute infection in the lungs, could develop secondary to another respiratory condition because the tissue resistance is reduced. Can be caused by bacteria, virus, or be acquired in the hospital. So that's that nosocomial infection that we're always trying to prevent as healthcare workers. The big concern with people with pneumonia is for people who have difficulty swallowing and chewing, that could create an aspiration pneumonia. So that's where if you have trouble chewing and swallowing appropriately, instead of those particles going into the digestive tract, they go into the lungs. If they stay there, then they can create an infection from there. So that can be really tough. 3 main types: lobular bronchopneumonia and interstitial pneumonia, which is also known as primary atypical pneumonia, or PAP. So here's a comparison of all the different, the 3 main types of pneumonias. Lobular pneumonia occurs in 1 or 2 lobes. Bronchopneumonia has scatter patches throughout. Same thing for PAP. You can look at the different causes for that. The pathophysiology of lobular pneumonia: inflammation of the alveolar wall, leakage of the cells, fibrin and fluid into the alveoli, causing consolidation. The pleura might become inflamed, and all this inflammation is going to limit gas exchange. Onset's quick, sudden, acute. Can also have high fevers and chills. Productive costs with rusty sputum. And then rales, one of those breath sounds we talked about earlier, progressing to absence of sounds in the affected lobes if all of that inflammation blocks the lobe itself. For bronchopneumonia, the inflammation and purulent exudate in alveoli, the purulent is that white, thick mucus type, often arising from prior pooled secretions or irritations. Insidious, gradual onset. Mild fever, productive cough with yellow maybe yellow-green type sputum, and dyspnea, difficulty with breathing. PAP, interstitial inflammation around the alveoli, necrosis of bronchial epithelium, variable onset, whether it's sudden, acute, or insidious, variable fever, headache, aching muscles, non-productive hawk and hacking cough. So that's the interesting thing about the PAP, it's the non-productive cough. Treatments are medications, antivirals, antibiotics, depending on what the exact reason for it is. Other medications as they arise, if they have a fever or you want to have something that reduces the fever. So the big thing for us in the rehabilitation medicine is airway clearance can happen with postural drainage or other things, other forms of the treatments we have. Potentially that postural drainage like we talked about, maybe mechanical airway clearance is the other thing for that. Energy conservation techniques. Christine, can you kind of give us some examples on what energy conservation techniques would be?
Yeah, I sure can. So for energy conservation techniques, what we need to start with is educating patients or clients on how much energy the different tasks that they're doing are requiring of them, so that they're able to sort of plan around how much energy they'll need to do their different tasks. And some examples of energy conservation techniques may be, if they are cooking, sitting down while they're chopping the ingredients rather than standing up. Going with the cooking example, having things arranged in their kitchen so that everything is within reach, and things that they use more frequently are lower rather than higher. Another energy conservation technique can be teaching patients how to move items from one surface to another more safely without having to carry as many heavy items. So putting them on like a wheeled cart or something like that. Taking breaks and doing some of the breathing exercises like pursed lip breathing, slowing down to do that. It can be sitting down while they're getting dressed, taking a rest in between. So for example, something for people with a lot of different respiratory diseases, one challenge, it can be very challenging just to take a shower, because if you think about taking a shower, it involves getting undressed, then showering, doing everything you need to do in the shower, and then getting dressed again. So if they sit down while they're getting undressed, maybe take a little rest. Another important part of energy conservation with respiratory disorders is to not have the temperature of the water too high so that it's not too steamy. Maybe they have a tub bench or tub chair, they sit down. It can be an equipment approach, so maybe using like a long handled sponge to scrub themselves with, having the removable shower head so that they're able to reach and shower themselves off. But taking breaks in between those tasks, getting out of the shower and then resting and then drying themselves and then getting dressed, but just taking lots of rest.
Yeah, I love breaking things up and finding ways that you can do the activity with also some rest. So that's great. So energy conservation for some tasks, so we can complete the task in a safe manner. Because man, if you're trying to get out of the shower and you're already fatigued, well, now you introduce slick surfaces, patient being wet, bench being wet, floor being wet. Man, it can be a really dangerous thing. So then our other task is potentially reconditioning. And with pneumonia, it's going to be one of those things where once the infection's under control, we can now bring you back. We can get you back to the prior level of function, and we can improve your respiratory performance. Other
Mhm.
things to consider, especially for our massage students, is muscle strains from coughing. Those, depending on how long pneumonia lasted for, coughing takes a lot of muscle power, and those muscles could be in a lot of pain. So maybe some pain guidance and some muscular treatments for those muscles themselves.
All right, COVID-19. So COVID-19 is a disease that's caused by the SARS virus, and its unique pathophysiological characteristics include rapid and firm attachment to the lung cells, particularly in people older than 60 years old and also immunocompromised individuals. So there are underlying conditions that contribute to increased risk. So most of these I'm familiar with. Obesity can contribute to risk, chronic lung problems. So for example, asthma, diabetes, asthma, chronic kidney disease. I'm not sure what a lover disorder is or how it increases the risk. But I'm going to have to ask you what that one is.
Yeah, because I wrote the PowerPoint. That's probably liver disorders. But I don't know. Maybe it is lover disorders. I don't know. Would you think that would be having too many lovers or not enough lovers? What would the disorder be?
I don't know, but I guess too many would lead to more exposure to potential COVID. So
yeah, right. Yeah, sure.
Yeah, so that's be something to consider. But liver disorders.
Yeah, I wrote this PowerPoint on Valentine's Day. I had love on the mind.
Hemoglobin disorders, and then serious heart conditions. So signs and symptoms of COVID-19. So the pathophysiology, the exact pathophysiology is poorly understood. This is something that is relatively new. So it's a single strand positive sense RNA virus, and it triggers a cytokine storm. So that's a severe immune reaction, and it causes too many cytokines to enter the blood too quickly. So this ends up causing the immune system to go into overdrive and causes widespread symptoms. So there's a huge variation of symptoms. Young people can be asymptomatic, but there are also people who are asymptomatic who are of any age as well. So general symptoms include fever and chills, coughing, sneezing, shortness of breath, fatigue, temporary loss of taste. And this is one of the symptoms that in some ways it helps to differentiate it from other diagnoses that involve things like coughing, sneezing, fever. Muscle and body aches, headaches, sore throat, nausea and vomiting, congestion, and even confusion can be some of the signs. So that's a lot of different signs and symptoms.
Yeah.
So treatment involves supportive care. So that can be pain relievers, cough medication, rest, fluid intake, and then severe cases can require mechanical ventilation and corticosteroids. So in rehab medicine, we're looking at airway clearance. We're looking at potentially postural drainage, definitely energy conservation, reconditioning, and then treatment for muscle pain from coughing exertion.
You know, one of the things with COVID, especially there's other things called long COVID, where their symptoms are lasting way longer than the initial infection. And I think for us in rehab, there are some conditions, pneumonia, the previous one that we talked about, that are pretty stereotypical. Someone with pneumonia, I know what they're going to look like before I actually see them. I just don't know to what severity. With COVID-19, man, because the symptoms are all over the place, we don't really know what we're going to walk into. So just seeing that diagnosis in the chart doesn't give us a whole lot to go on. So we have to be really flexible and really dynamic with our treatment approaches for with someone with COVID-19.
And what are some of the treatment approaches that you've used the most in, say, a home care setting?
Well, most of it is reconditioning so that they can function within the home and then enter and exit the home safely. So it's a lot of endurance training, and that can be really tough. The other things that can be really tough is my patients with long COVID with brain fog, the confusion part of it can be really tough. So a lot of emotional support too. So,
And then from the acute care perspective, one of the interventions that is used is getting people to change their position rather than lying down in the bed. But one of the main things, the priorities, was patients who have COVID to get them up into their chair for a couple of hours just to change their position.
yeah.
And that's part of the postural drainage as well.
Yep, absolutely. Next one I want to talk about is tuberculosis. Now, I find tuberculosis fascinating. And when I first thought that, I saw this in the textbook, I thought like, oh, we don't have to teach this. This isn't a problem. But I didn't realize that tuberculosis used to be in a decline and thought to be under well under control. However, in the last decade or so, tuberculosis has been increasing globally, especially in areas of crowding, cities, anywhere people are close proximity to one another, higher incidence in areas of poverty, and also people who have AIDS. This is a common secondary condition that they can acquire, or sometimes called opportunistic infection. The United States rates in areas of HIV and homelessness are high rates, similar to those in developing countries. So it is not somewhere else in the world that this is, although it's everywhere in the world it's increasing, it's also in the United States as well. 2 million people worldwide are affected with tuberculosis, and around 2,000 deaths per year globally. The pathophysiology is pretty fascinating. The infection caused by the Mycobacterium tuberculosis, and what are the odds the tuberculosis bacteria would cause tuberculosis? What a coincidence, huh? The primarily affecting the lungs, but can invade other organisms. It's a slow growing bacteria that is somewhat resistant to drying and other disinfectants. So microbes can live in dried sputum for weeks on end. It is destroyed by UV light, heat, alcohol, glutaraldehyde, formaldehyde, but the cell itself is resistant to the body's natural defenses by the neutrophils. So there's two stages of the pathogenesis. Primary infection is when the microorganism first enters the lungs. That organism, that bacteria, becomes engulfed by macrophages, which creates the local inflammatory reaction. In a healthy individual, those lesions are going to calcify. The macrophages engulfing the bacteria is going to calcify, and we can see that on X-ray for years after the initial infection. So could take 6 to 8 weeks for that immune response, but the calcified cells of the dormant bacteria might remain in someone for years to come, and that bacteria that remains viable. So someone can have their first infection, have little to no immune response for it, never know it. Maybe they had a cold for 2 days and that's all that the symptoms it was. But years down the road, this can then turn into an active tuberculosis infection. So the secondary infection for people with low resistance, primary infection not controlled, and progressive to active infection. Oftentimes this arises years after that first introduction to the primary infection. The microorganism multiplies, destroys tissues, and then the bacilli is present in the sputum and now can be passed to others. So that's what I think is so unique about tuberculosis, is that it can be dormant, seen on X-ray, but dormant for years after we first come in contact with the bacteria itself.
And is that part of why we have to get the PPD?
Yes.
Because it could be exposed and be carriers.
Right. Transmitted by oral droplets released by a person with active infection, can also be passed by milk that's not pasteurized. So that was a new thing that I learned about tuberculosis as well.
Mhm.
Again, it occurs frequently in crowded positions or people with low resistance, like an immunocompromised disease like AIDS. So signs and symptoms: primary tuberculosis, asymptomatic. Again, it's a localized inflammation response, minimal appearance, any signs or symptoms. The secondary tuberculosis, insidious, gradual onset, vague signs and symptoms like anorexia, malaise, fatigue, weight loss, afternoon low-grade fever with night sweats,
Mm.
prolonged cough that becomes more severe and more productive over time, and purulent sputum often containing blood. So if primary tuberculosis is discovered, some people are given medications to prevent the infection from becoming active. Active tuberculosis is typically treated at home or in the hospital, depending on the patient's overall health condition. Long-term treatment, so greater than between 6 months to over a year, with a number of different drugs. So if it becomes active, you can be on drugs for a long, long time. So for us, the first concern is to protect the healthcare worker. How do you become protected? We're going to be on droplet precautions. That means we're having face shields, full gowns, full gloves. We're really protecting the healthcare worker if we have a patient who has active tuberculosis. But we also want to prevent nosocomial, hospital-acquired spread. Patient-specific strategies could include energy conservationist techniques that you talked about earlier, reconditioning exercises, pain management, nutrition, and then also patient education on hygiene. So we're also next going to talk about just two common categories of lung diseases: obstructive versus restrictive. Obstructive have to do with airway blockage. Mucus is now blocking the airway itself. So less air can be exchanged because the mucus is blocking the airways, narrowing the airways. Versus restrictive lung diseases, which causes the failure of lung expansion. Scarring of the lung tissue, limiting its flexibility, is a good reason for that. Well, I guess not a good reason for it, but an example of it. So first up, cystic fibrosis. I think there's supposed to be 1 in 3,400 births, not 1-3. Births from white European descent parents are 1 out of roughly 3,400 births if the parents are white and European descent. 1 in 12,000 if the parents are from African ancestry. So for some reason, genetically, it happens more often in white European descent families. And it's an inherited disorder in children. Mean age of survival is 37 years of age. That is up significantly in the last 20 years. 20 years ago, it was in the mid-20s was the average age of survival. Now, my friend Will, this isn't a picture of Will, but my friend Will was diagnosed at the age of 35. So there's an article there. Go ahead and read it. Pretty fascinating on how he got diagnosed and how everything in his life finally clicked when he finally got that diagnosis. How he always had pneumonia. How he never was able to put on weight. So pretty fascinating article and diagnosis. Again,
What's the Cliff's notes of how he got diagnosed?
He was having trouble. He and his wife were having trouble conceiving a child. And one of the signs and symptoms for people who have cystic fibrosis is defect in the vas deferens for males. So the sperm has nowhere to get out. So yeah, pretty fascinating that he had that. So also crazy that the Mean age of survival is 37 years old, and he was diagnosed at 35. So pretty crazy to see that. Anyway, so the pathophysiology, it's a genetic disorder, mutations from the cystic fibrosis transmembrane conductance regulator gene. So another crazy coincidence. What a crazy coincidence that the cystic fibrosis gene could cause cystic fibrosis. Mutation causes abnormally thick secretions, and it primarily affects are seen in the lungs and pancreas, where the sticky mucus obstructs the passages. Severity varies among individuals, and like we said, my friend Will, he was very mild for most of his life, and then it finally clicked in for him when he did get diagnosed. The lung mucus obstructs airflow in the bronchioles and small bronchi. Air traps in the lungs called atelectasis and damages the bronchial walls. The stagnant mucus also allows bacterium to grow, so infections are common. Mucus also obstructs the small intestine, blocks the pancreas from releasing digestive enzymes. One of the reasons why people with cystic fibrosis tend to be really thin as well. The saliva and sweat have high concentrations of sodium chloride. So this is salty baby syndrome. This is how I always remembered it. And one of the ways that a lot of kids get diagnosed, babies get diagnosed, is their parents tell their pediatrician they taste salty when I kiss them. So it's just an excess of the sweat and saliva have excess salt in it. So again, it's the autosomal recessive disorder, mutated gene on the 7th chromosome, more common with white Northern European descent compared to other ethnicities, many asymptomatic carriers of it. So signs and symptoms, salty skin, like we just talked about, might require a sweat test to see that. Stools are bulky, fatty, foul in smell, because again, the pancreas is being blocked from releasing a lot of digestive enzymes, so the body's not digesting a lot of the nutrients and it's just passing right through. Potentially a distended abdomen, failure to gain weight, chronic cough, frequent infections, respiratory infections, progresses to hypoxia, fatigue, and exercise intolerance. Could have failure to meet normal growth milestones as the child is developing. So slow to learn how to sit independently, crawl, walk, could have some potential delay in growth milestones. An interdisciplinary approach to our treatment because of the multi-system involvement, maybe replacement therapy for pancreatic enzymes, definitely nutrition guidance, bronchodilators and humidifiers, aggressive treatment when when infections do start occurring. We're going to treat them right away. Heart and lung transplants have been performed with patients with cystic fibrosis. But the rehab medicine includes daily chest PT, postural drainage, percussion, coughing techniques, moderate aerobic exercises are also helpful. And I wanted, here's a picture of a vibration vest. So this vest can be latched onto the person. It fits pretty snug, and then you plug it in and the vest then vibrates to help try to clear mucus. You can watch this video. I want to show one thing on it. Let's see if I can find it. Christine, you're seeing the video now?
Yep.
Okay. So this is Boomer Esiason, former NFL quarterback. This is his son, Gunnar. So Gunnar has cystic fibrosis. You'll see there's some breathing treatments, and there's part of the percussion. You can see, I like watching this because you see, big old football player, 6'4" quarterback, big hands, and seeing he's got a really nice cupped hand appearance, a little tough to see in this video, but he is, it is aggressive with the amount of force that he's using. You can see the kid's head bobbing up and down. Like it is a decent amount of force trying to move these secretions, get this mucus that's lodged in the lungs, get it to move. so that they can then clear the airway and improve breathing. So that's cystic fibrosis. So again, daily treatment is the thing for anybody with cystic fibrosis.
Okay, lung cancer. So lung cancer is the third most common cancer in the US, about 228,000 new cases a year. So there's more information about the overall topic of cancer that we're going to be covering in the oncology section of the course. The pathophysiology of lung cancer, there can be a small cell lung cancer, so about 13% of cases, and that has a higher mortality rate, or a non-small cell lung cancer, and that's 84% of cases, and that's more responsive to chemotherapy. So it's rare to have benign tumors in the lungs. And also the lungs are a common site for metastases of cancers due to increased blood flow to the lungs. So with that increased blood flow, it can support the metastases of the cancer to the lungs from different areas of the body. And then tumors themselves can obstruct the airways, and also the inflammation around the tumors can also obstruct the airway as well. The etiology of lung cancer, so smoking and also secondhand smoking, are major causative factors of lung cancer. And then other factors can be genetic as well as environmental exposures. So environmental exposures to silica, vinyl chloride, and asbestos. And signs and symptoms and treatment. So signs and symptoms, so there's an insidious onset, a productive cough, dyspnea, which is shortness of breath, wheezing, hoarseness, weight loss, and pain. And then detection of cancers typically from a chest or shoulder x-ray. So it's important to also consider if you have a patient that has unresolving shoulder pain, who also has a history of smoking, and any other signs, that maybe that's something to consider when they have
I've had two patients I was seeing for shoulder physical therapy, and just not getting where we needed to. Sent them back to the docs. Docs took an x-ray, nothing wrong with the shoulder, but in the corner of the x-ray where it captured a piece of the lung, they saw a spot and they start investigating further. So important for all of our professions, massage PT and OT, to consider that if this shoulder pain is unresolving, it's not really getting better, and if we know they have a history of smoking, suggesting an x-ray is probably a great idea for us to look with our patients. What treatments do we have for lung cancer?
So there's surgery, there's chemotherapy, radiation, and immunotherapy are typical treatments for lung cancer. And then the rehabilitative approach, so being aware of the possibility of lung cancer. So always remember that part of being a rehab team is that you are extra time of eyes and ears on the patient. So we're always contributing to a diagnosis or updating a diagnosis. We don't diagnose, but we do observe things and we report those to the team and also in our documentation. So if you're aware of the example that Josh just gave with shoulder pain, being aware of the possibility and communicating that. Addressing new issues, so there can be pain, there can be challenges and barriers with range of motion, strength, there can also be deconditioning, and also after the cancer treatment effects, then using some of these approaches as well.
Aspiration isn't necessarily something we're going to talk about a lot, but since we are part of the team, we could see signs of this. So aspiration is the passage of food, liquid, vomit, drugs, other foreign material into the trachea and the lungs. So it's not going into the digestive tract, instead it's going into the lungs. right lower lung, most common site for aspirated material, just because anatomically the pathway is just straight down. Trachea right to the right lower lung is vertical. So common in children, also are at risk for any condition that decreases the ability to chew or swallow. Maybe anesthesia is the reason for that, stroke, other neurological damage, or people with diminished gag reflexes. For our approach, again, the speech language pathologists are probably going to be the ones that directly treat the difficulty chewing and swallowing. But we're all at observers of our patients. So as we're doing exercise, as I have my patient sit down and have a drink of water, if they're always coughing after they take that drink of water, that's a sign that they are aspirating, that their lungs are trying to get that water back out of where the airway. So it's important for us to be aware of it. Some things we can also do, maybe we can have our patients lie down to either take medications or drink water, because then the gravity isn't going to push that material straight down into the lungs. So that potentially could help. We can also have thickened liquids. We can tip our chin to our chest when swallowing. That helps close the epiglottis. So there's a couple things we can do, and we can also just ask our speech language pathologist for advice and, hey, what do I look out for? And I think it's especially important in the OT world, because you guys are directly working on how people can eat and the mechanics of that, right?
And with any of the interventions, like taking medication lying down, thickened liquids, those are things that I would reach out to a speech language pathologist first to get their opinion before doing any of those. But in occupational therapy with aspiration, a lot of it is looking for the signs and being able to, again, report that to the team, because something that we do with occupational therapy is work on self-feeding techniques using different equipment. And so we may be working with someone who has a history of stroke, and we're working on helping them be able to scoop their food from their plate and bring it to their mouth. But if we start noticing the coughing, or that they have like a gurgling sound, like their food isn't being swallowed all the way, those are things that we want to report to the speech language pathologist to maybe do a swallow eval if they're not already working with them, so that they can be involved in the team approach as well.
Yeah, definitely.
Another intervention with aspiration to consider too is that if you are wondering if someone's aspirating, to have them sit up for a little while after they do eat.
All right, good.
And then asthma. So asthma is a disease that involves periodic episodes of severe but reversible bronchial obstruction. So this can be frequent repeated attacks of acute asthma and can lead to irreversible damage and lead to chronic asthma. So acute attacks can be superimposed on chronic asthma. There has been a rise since the 90s in acute asthma requiring hospitalization. So around 15 million people in the US have asthma. So asthma can be classified as acute or chronic. It can be on a scale based on severity from mild and intermittent to severe and persistent asthma. As extrinsic, so where acute episodes are triggered by an inhaled antigen, or intrinsic, so typically adult onset or other types of stimuli like exposure to cold, exercise, stress, cigarette smoke, even medications like aspirin, target hyperresponsive tissues in the airway.
I think that's one of the tough things about asthma. We have a few different classifications of it, right? So I always think acute versus chronic. Somebody can have asthma, once you have it, you're not going to get rid of it. And the acute episode of asthma happened yesterday. We had an acute asthma attack. We needed some interventions. We'll talk about that in a minute. Some other classifications, mild asthma, severe asthma, so I think that's one of the tricky things about asthma, because we have a few different ways we categorize it. So
Mhm.
I don't think that's too important for our class right now, but as our students start working with people with asthma, you might see some of these terms. Anyway,
Mhm.
go ahead and keep going. Sorry to interrupt you.
That's all right. So the pathophysiology of asthma. So the bronchi and bronchioles respond to a stimuli with inflammation of the mucosa with edema, and then contraction of the smooth muscle. So that's bronchoconstriction, and then increased secretion of thick mucus in the passages. So the changes either partially or totally obstruct the airway and limit airflow and oxygen supply. And then the second stage, so a few hours after the start of an allergic response, is that there's increased leukocytes release additional chemical mediators, and that results in prolonged inflammation, bronchoconstriction, and epithelial damage. So this causes more airway obstruction. Then partial obstruction of small bronchi and bronchioles results in air trapping and hyperinflation of the lungs. So as a result, it becomes more difficult to inspire or breathe in the fresh air, or to cough effectively to clear the mucus. So a complete obstruction of the airway results when there's a mucus plug that blocks the airflow from an already narrowed airway. And then this leads to non-aeration or atelectasis of the tissue that's distal to the blockage. And then the air in the distal section diffuses out and is not replaced, and that section of the lung collapses. Persistent asthma attacks can lead to hypoxia, cardiac arrhythmias, thickening of the bronchial walls, and fibrous tissue growth in areas of atelectasis.
Yeah, what a cascade of events once we have that whatever the trigger is for that person, as simple as cold could be it.
Yeah,
But whatever that trigger is, that really the cascade of events that happens to create the problem is pretty fascinating, pretty severe.
yeah. And then signs and symptoms of asthma. So the etiology, there can be a family history of hay fever, asthma, or even eczema is common. Viral upper respiratory infections can precipitate attacks. And then other contributing factors can include sedentary lifestyles, exposure to allergens, poor indoor ventilation, and increased air pollution. Sometimes people aren't even sure where in their environment they're being exposed, that
Right.
they're having their asthma triggered. So there can be, for example, molds that they're not aware.
Yep.
Um, or maybe they have an allergy to a pet that they're not aware that they have, things like that.
How would you not be aware you have a pet?
Sometimes it just sneaks up on
Oh
you.
my God, I have a bird as a pet. I didn't realize.
So signs and symptoms are cough, dyspnea, a tight feeling in the chest, potentially unable to talk, or even a change in the sound of the person's voice. Maybe their voice becomes more soft. Wheezing as air escapes the narrow bronchioles, increased respiratory rate and increased labor of breathing, including use of accessory muscles. Thick mucus can be coughed out, tachycardia, hypoxia, and if there's respiratory failure, then decreased responsiveness or cyanosis. And then the treatment of asthma. So minimizing the frequency and severity of acute asthma attacks is important to prevent lung damage, to reduce risk of infection and the development of obstructive lung disease. So general measures are, of course, identifying the allergic reactions. Like I said, sometimes people just aren't sure what's triggering it. Avoidance of common triggers, so airborne irritants, good ventilation at home, at school, or at work, exercise like swimming and walking, and medications for lung performance, as well as prophylactically for colds. And then for acute asthma attacks, bronchodilator medications, so inhalers and other breathing treatments. And then controlled breathing techniques that can improve gas exchange and also decrease anxiety, because when we were looking at that cascade of events of having asthma, even for an acute attack, that it can start out mild, along with the difficulty in breathing, there's going to be anxiety, and then that can exacerbate the difficulty in breathing.
And the controlled breathing technique that we talked about earlier, the 4x4, right? 4-second in, nice and slow on the way in, hold it for 4, nice and slow on the way out for 4 seconds. That's a perfect example of the use of that 4x4 method.
Yep, absolutely. And then rehab approaches. So being aware of triggers like cold temperature. Sometimes it can be from going from one temperature and then a drastic change to another. So just if it's nice and warm inside and you step outside and it's really cold outside, that can trigger asthma. Exercise-induced asthma attack. That's especially something to be aware of when doing therapy with someone where you're doing any type of exercise. Environmental irritants and allergens. So being aware of what those triggers are, and then ensure proper ventilation of a clinic or wherever it is that you're treating the patient or the client. And then it's really important, if you know a person has asthma and that they use a rescue inhaler, make sure that they have that on hand when you're performing treatments. And that can be for massage therapy, physical therapy, and occupational therapy.
Yeah, and I mean, some of these irritants, especially I'm thinking in the massage world, some of the scents of lotions and other things, maybe setting up the environment with some diffusers or things like that. You know, the patient might not even know that those are triggers for them. So,
Yeah,
important.
I was just going to mention the chemical irritants for some people. So those are examples of that. Yeah.
Yeah, I think it's easy. Oh, okay, we're going to do exercise. Do you have your inhaler on you? I think that makes a little bit of sense. But even in something sedentary like massage, where the patient's, you know, it's passive for the patient, we could be still exposing them to some irritants. So, so COPD is a chronic obstructive pulmonary disease or lung disease. COLD would be, it's the same thing, just different abbreviations, because why make things simple? Common group of disorders characterized by progressive tissue degeneration and obstruction of the airway of the lungs. Oftentimes will lead to right-sided lung failure, right-sided heart failure, that should say, or also known as cor pulmonale. So right-sided heart failure is what that should say. Another little error. COPD, fourth most common cause of mortality in the United States. The three specific conditions that we'll look at: emphysema, chronic bronchitis, and acute asthma, we already covered. So emphysema is due to the destruction of the alveolar walls, decreased surface area for gas exchange, losing elastic fibers, affecting the ability to recoil on expiration. So the thickening of the bronchial walls leads to narrowed airways, weakened walls, interference with passive expiratory airflow. And the progressive difficulty with expiration leads to air being trapped in the lungs and overinflation of the lungs, fixation of the ribs in the inspiratory position, causing the barrel chest appearance. So so these people have trouble getting the air out, and they're just over time going to keep more and more air in, and their lungs and ribs are going to become always inflated. Also a flattened diaphragm on x-ray, because again, the lungs are pushing down on the diaphragm. Smoking is the most implicated cause of emphysema, but there are some genetic factors as well as some air pollutant exposure that can contribute. Insidious onset, developing with dyspnea, with exertion at first, and then even at rest later on. Hyperinflation with prolonged expiratory phase, use of accessory muscles, with a tripod position to breathe. That's where you're stabilizing your hands on something, you're fixating your hands. That way your scapular muscles can then pull on the rib cage to try to increase that lung expansion. Forward leaning to attempt to use accessory muscles to breathe. That's what that tripod position is. Oxygen levels remain level until later stage of disease because the body can't compensate to it. Anorexia, fatigue, clubbed fingers, and increased red blood cell production develops as a compensation as well. So the treatment: smoking cessation, avoidance of irritants, protection against infections, common ones, flu and pneumonia, nutrition and hydration focus, bronchodilators, as well as oxygen as the disease progresses. Sometimes lung reduction surgery can be helpful because if you reduce the trapped air part of the lung, the rest of the lung can become more efficient because of it. However, there's long recovery time and increased risk of complications. So I have not seen one of those happen. For physical rehab, exercise is good, and trying to improve walking endurance, breathing exercises, specifically exercise that focus on the expiration. So pierced lip breathing, we're able to have a lot of pressure as we're getting air out. Energy conservation techniques, we've learned a little bit, but now also, because oxygen is likely going to be used, oxygen safety, making sure there's signs, making sure there's no open flames, and oxygen line management, like we talked about, to reduce trip hazard. Chronic bronchitis, defined as a productive cough lasting at least 3 months, with recurring bouts occurring for at least 2 consecutive years. So 3 months of productive coughs, 2 years in a row is the formal definition of chronic bronchitis. Differentiated from other COPD conditions by significant changes in bronchi from constant irritation, like smoking or industrial pollution. It is progressive and irreversible. Inflammation and obstruction, repeated infection and coughing will cause the mucosa to become inflamed and swollen. Hypertrophy of the mucus glands, which now increases more secretions. Chronic inflammation and irritation leads to fibrosis and thickening of the bronchial wall, which leads to further obstruction. Secretions pool distally into the thickened bronchial wall and then are more difficult to remove. Oxygen levels are low and cyanosis can be seen. So that's important differentiation between emphysema as well. Severe dyspnea and fatigue, pulmonary hypertension, and can cause cor pulmonale, which is the right-sided heart failure, not lung failure, right-sided heart failure. So signs and symptoms, well, the etiology, like we talked about, cigarette smoking, living in an area where pollutants are high, smog is common. Exposure to inhaled irritants leads to inflammation. Frequent infections initiates a cycle. Asthma can also be an associated condition. So the signs and symptoms are constant productive cough, tachypnea and shortness of breath. Frequent secretions are thick and purulent. Cough more severe in the morning. Has to do with the positioning, like we keep talking about, the laying flat for a while and then the mucus staying stagnant there. Airway obstruction leading to hypoxia, which leads to cyanosis. That's that bluish tint, not enough oxygen in the body. The increased red blood cell production, weight loss, polycythemia, and right-sided heart failure, cor pulmonale. So the treatments, again, stay away from irritants, make sure we're up to date on our vaccines because we don't want a secondary infection with it. Expectorants and bronchodilator medications. So for us in the rehab medicine world, postural drainage, percussion and vibration, assisting of mucus removal are the big things, and then energy conservation techniques. Because this is a progressive and irreversible disorder, we are no longer looking at reconditioning like we would be for somebody with maybe pneumonia or COVID. we are more towards how are we going to adapt our lifestyle to this disease rather than let's adapt your body after having this disease. So it's a different approach that we have to make sure we understand and our patients understand too.
Another energy conservation approach is teaching people body mechanics, proper body mechanics for the different tasks that they need to do. So, for example, how they're positioning their body if they need to carry something, so that their body's not having to work quite as hard.
Right, right. So one of the common ways that I shouldn't say we, because you and I don't, but what is often referred to the kind of sayings are the pink puffers versus the blue bloaters. The emphysema are known as the pink puffers. So they're pink because until the later stage of disease, the oxygen levels remain high, but the in bronchitis, the chronic bronchitis, blue bloaters, because the person is now have low oxygen, that's that cyanotic appearance. Also with emphysema, the weight loss and the difficulty with gaining weight could be part of it as well. So I think if our students watch other videos on I don't understand this stuff, they might see videos that refer to someone as a pink puffer or a blue bloater. I think also clinically we'll see maybe some of our colleagues referring to patients as these. How would you feel if somebody called you a blue bloater there, Christine?
Yeah, I think my feelings would be hurt, and it's dehumanizing to call
Yeah,
someone a blue bloater or a pink puffer. I can't even picture referring to a patient as a pink puffer or a blue bloater, even if it was a way to describe the combination of symptoms that they had, because that's a human being who is living their life with this diagnosis, and it just feels like name calling.
yeah,
That said, it has been used for a long time, and you may come across it. And if you look at this image, it does paint a picture, but
right.
maybe we could somehow come up with names that are a little bit more respectful of what the collection of symptoms would look like in a patient.
All right, I'll start working on that.
Don't even get me started.
So here I just have a comparison of the three different COPD diseases that we talked about: emphysema, chronic bronchitis, and the acute version of asthma. So feel free to look at that. I'm a big chart guy. I love looking at charts. So I think that might help some of our students. Now, restrictive lung disorders is where lung expansion is impaired and total lung capacity is reduced. So total lung capacity we looked at earlier in the anatomy and physiology review. Some diseases have both obstructive and restrictive components: pneumothorax, scoliosis, ALS, muscular dystrophy. We're going to focus on pulmonary embolus for our class here. So a pulmonary embolus is a blood clot that obstructs the pulmonary artery or a branch of it. The blocks blood flow from entering the lung tissue. Most often it's a piece of a blood clot from deep in the leg vein that broke off and traveled into the smaller pulmonary artery. Leading cause of death in hospitals: 600,000 cases a year with 60,000 deaths. That's a really high mortality percentage for a condition. Most of the deaths occur within the first few hours of symptoms developing. So a moderate sized emboli breaks off and lodges into the pulmonary artery. Respiratory impairments because of fluid fill the alveoli, and blood fill the alveoli of the involved area. Reflexive vasoconstriction occurs, which increases pressure in the blood vessels. Larger emboli involve over 60% of lung condition, and sudden death often results from a larger emboli. Around 90% of pulmonary embolus have originated from deep veins, mostly in the legs. So the risk of those blood clots are immobility, trauma, surgery to legs, post-childbirth is another common one, congestive heart failure, dehydration, other conditions that would increase coagulation of blood, and as well as cancer. So signs and symptoms: a small size PE, transient chest pain, cough, dyspnea, tachypnea, hypoxia. Again, compensations to overcome the blockage. Large size, crushing chest pain, low blood pressure, weak and rapid pulse, loss of consciousness. The treatment is rapid blood thinners, potentially mechanical ventilation, and maybe surgery might needed. So for us, I think what we're going to see most often is the prevention of this, educating our patient on why, even though those compression stockings are tough to don and doff, why it's important. Early ambulation, trying to get that person mobile as fast as possible, constant mechanical movement of lower extremities potentially. Prophylactic blood thinners are often prescribed after surgeries, so even something as little as an aspirin.
I would even add, for prevention, educating them on signs of DVT, the deep vein thrombosis, so that they recognize, because in that case, they would not want to be moving a lot.
Right. Yeah, no, if you have signs of a DVT, we call 911 right away. Yeah. Yeah. So, yeah, prevention is the key for PE for us. So, well, thank you for spending some time with me, Christine. I'm going to go hit these waves over here.
Enjoy.
Yeah, and we'll talk
What do you
soon.
have, a boogie board?
Yeah, I'm going to put my swimmies on.
Okay.
Yeah. So
good.
We'll go do that.
Well, enjoy.
All right. Thank you. You have a great one. Good seeing you.
Bye.
Bye.